At approximately 10 p.m. on a night shift, my crew was called as a code 1 to a 49-year-old male complaining of shortness of breath. Upon arrival, it was immediately evident that the patient was in severe respiratory distress as he was in tripod position and breathing rapidly with the use of accessory muscles. My role was to gather the patient history and complete other secondary assessments such as a respiratory status assessment. This patient had no previous history of respiratory distress such as asthma and was on no regular medications. He did, however, have a recent chest infection that he was taking steroids for, though he had finished his prescription a few days prior to this event. A respiratory status assessment revealed that the patient's skin was pale and clammy, was only able to speak in short phrases, and had audible wheezes before chest auscultation. Whilst auscultating his lungs, inspiratory and expiratory wheezes could be heard. His respiratory effort was increased severely with the use of accessory muscles, his rhythm showed prolonged expiratory phase, and he was tachypneic at a rate of 40. His vital signs showed that his ECG was sinus tachy at a rate of 110. His oxygen saturations were 92% on room air. All other vital signs were within normal limits. A treatment for this patient was salbutamol and Atrovent nebulized at 8 liters per minute of oxygen. He was unresponsive to treatment and transferred to hospital under a code 1 as it was time and transport critical. This case is relevant as a significant proportion of pre-hospice care comprises of respiratory complaints and is a major part of my learning in paramedicine. In this particular incident, it was the exacerbation of his chest infection that led to the acute onset of respiratory distress. I have not experienced a chest infection severe enough to cause acute respiratory distress, nor did I have significant knowledge or skills to be able to treat this issue. I do, however, have knowledge and skills to treat asthma-related respiratory distress, which is a treatment path my mentors took. Therefore, I was able to administer salbutamol and provide reassurance. I could relate this skill to that performed in the classroom when practicing in scenarios. After the patient's prescription ran out, it was the gradual worsening of his chest infection that was the underlying factor of the shortness of breath. I was later informed by the nurse at ED that the chest infection was a mixture of pneumonia and bronchitis. According to Curtis and Ramsden 2010, the pathophysiology of pneumonia is bacteria bypassing the multiple defense mechanisms of the lungs which activates the immune system, releasing inflammatory mediators. These inflammatory mediators caused bronchial mucous membranes damage to the bronchial mucous membranes and alveolar-capillary membranes, thus causing the bronchioles to fill with debris and causing wheezes. According to Yoshida, Boylan and Kavanagh, 2015, it is of high importance to understand the nature of the respiratory distress as there are various causes and therefore different treatment options. By understanding the pathophysiology, it gains a better understanding of what is occurring inside the lungs and aids in critical decision making to provide the best care for the patient. For example, Murray et al. Explained that respiratory distress could have been cardiac in nature, which would have changed their plan of treatment for this patient. From a patient perspective, it would have been a frightening situation, especially since it was his first time experiencing respiratory distress. As a student paramedic, it was also my first time seeing someone have severe difficulty breathing, and I was a little unsure what to do. From my mentor's perspective, they understood that this was life-threatening and time-critical, but realized the importance of remaining calm and reassuring the patient. In my future practice, I will now have a better understanding of the pathophysiology of pneumonia and how, in severe cases, can cause respiratory distress. If I came across this situation again, I would definitely act faster while still following a systematic approach. I would also call for critical care paramedic backup as, according to the QAS Drug Therapy Protocols 2015, they can provide more treatment options, including intravenous hydrocortisone for the exacerbation of COPD. Although the QAS Drug Therapy Protocol states that hydrocortisone has a long onset time, it might work in this particular patient as this drug is a corticosteroid, meaning that it releases an anti-inflammatory response, which inhibits the accumulation of inflammatory cells. Since the pathophysiology of pneumonia is caused by the inflammation in the lungs, which leads to bronchioles constricting and filling with debris, I believe this drug would work for this patient. My theory is backed by Confalonieri et al.'s 2005 studies which highlight that hydrocortisone leads to an earlier resolution in severe cases of pneumonia, and it reduces the inflammation. Additionally, it has been proven to decrease further complications such as sepsis. I believe that after reflecting on this case, I will be able to make changes in my future professional practice as a paramedic, and I will be able to benefit other patients who present in this similar condition as this case.